Hello, this is Steve Bonsib from Arkana Laboratories in Little Rock, Arkansas. This is the fifth segment of my series of developmental abnormalities in cystic kidney disease lectures. The previous four lectures are listed as you can see here. Today I would like to discuss a ciliopathy, nephronophthisis, and autosomal dominant tubulointerstitial kidney disease. I'm discussing these together because they have clinical features in common as well as morphologic features in common as well. Before I discuss the individual entities, I'd first like to discuss some terminology because there's been significant evolution over the last 40 or 50 years. The term medullary cystic kidney disease was first coined by Smith in 1946. This was obviously because of the distinctive gross findings in advanced disease of medullary cysts, which he noted in autopsy kidneys. In 1951, Fanconi first coined the term familial juvenile nephronophthisis, obviously referring to its familial nature, and phthisis referring to atrophy or disintegration of nephrons. And certainly in advanced stages of disease, we see that on biopsy. In the latter portions of the 20th century, these were kind of lumped together and referred to as nephronophthisis, medullary cystic kidney disease complex, because of their similar clinical and pathologic features. Awareness of the genetic heterogeneity gradually led to separation of the two entities, with nephronophthisis reserved for the autosomal recessive disease and medullary cystic kidney disease for the autosomal dominant disease. Medullary cystic kidney disease was then divided into type 1 and type 2. In the early 21st century, it was recognized that nephronophthisis is a ciliopathy, whereas autosomal dominant medullary cystic kidney disease, four distinct mutations were identified as listed here. Uromodulin, which is also known as TAM-Horsfall protein, Mucin-1, also known as epithelial membrane antigen, renin, and hepatocyte nuclear factor 1 beta. In the last 10 to 15 years, the medullary cystic kidney disease terminology has gradually transitioned into autosomal dominant tubulointerstitial kidney disease, since medullary cysts are uncommon and an inconsistent finding. That said, nephronophthisis, shows a similar demonstration of infrequent cysts at onset, and even in advanced disease may not have medullary cyst. Currently, 6 mutations have been identified. If we begin with nephronophthisis, this is a very rare disease. The incidence is 1 in 1.2 million in the United States, although there is geographic variability. It is the most common monogenetic cause of end-stage renal disease in the first 3 decades of life, accounting for about 15% of pediatric end-stage renal disease. It is a complex disorder. 25 mutations are currently known, but these only account for 50 to 60% of the cases, so many more mutations will likely be identified in the future. NPHP1 homozygous mutation, which encodes for nephrocystin, is responsible for 20 to 25% of all cases, and 64% of those cases in which the gene responsible was identified. Therefore, NPHP1 is always going to be our first diagnostic consideration in a biopsy that shows features consistent with nephronophthisis. Nephronophthisis is most often renal limited. However, it may have a number of extrarenal malformations in 15 to 20% of the cases. These are sometimes referred to as nephronophthisis-related ciliopathies. I've listed 3 here, but there are additional malformations of the central nervous system, skeletal system, and heart, which may be encountered. I will not be discussing these syndromic forms further, but if you're interested in additional insight into these. The excellent review article is listed here by Wolf et al. In Pediatric Nephrology. Nephronophthisis has a very typical clinical phenotype. It's usually an infant or child, or maybe an adolescent, with otherwise unexplained chronic kidney disease. Polyuria and polydipsia are marked due to a significant concentration defect, and this often leads to bedwetting as a problem. There's growth retardation and anemia disproportionate to the degree of chronic kidney disease. Pertinent negatives: there is no hypertension, proteinuria is minimal to absent, and there is no hematuria. And it's important for other causes of a chronic tubulointerstitial nephritis to be excluded, such as drug exposure, supplements, or other nephrotoxins, and especially urinary tract infections. Nephronophthisis presents in 3 clinical subgroups. There's an infantile form, a juvenile form, and an adolescent form, and they vary in the mean age of onset of end-stage renal disease. The infantile form develops end-stage disease at age 4, juvenile an average age of 13, and adolescent an average age of 19. The infantile form is very rare, and NPHP2 and 3 mutations account for most cases. The juvenile form is the most common, and the NPHP1 mutation is the most common mutation identified. The adolescent form is important because it overlaps with the age of onset of autosomal dominant tubulointerstitial kidney disease. The pathologic features of nephronophthisis: importantly, renal development is normal at birth, and at clinical presentation, kidney size is usually normal or may be small if there is a significant component of chronic kidney disease. However, in the infantile form, the kidney size is often enlarged because, as we'll see, they form cyst formations at an earlier stage of disease. Corticomedullary cysts are infrequent at presentation, but increase in number over time. They are present in about 70% of autopsy cases, which means 30% of cases will never develop corticomedullary cysts. And unfortunately, corticomedullary cysts are usually not present at the time of clinical presentation. The biopsy shows a generally nonspecific chronic tubulointerstitial nephropathy or nephritis. Different authors will use different terms, nephropathy or nephritis. Inflammation is present and at times is quite prominent, as we'll see. My preference is to use the word nephritis, but I must admit I am not totally consistent in the use of this terminology of nephropathy or nephritis. The NPHP1 and infantile nephronophthisis have several distinctive histologic features, as I'll get to in a moment. This is a low-power image of a typical example of nephronophthisis, showing the chronic nonspecific chronic tubulointerstitial nephritis. As you can see in the left panel, the inflammation is quite brisk, but it is limited by and large to the areas of tubular interstitial scarring. There is relative glomerular preservation, and by that I mean you can see relatively intact glomeruli within these areas of advanced scarring. There is periglomerular fibrosis, which is a typical feature of a chronic tubulointerstitial process. Here on trichrome stain, again, we can see fibrosis in the areas of atrophy, although it's not as prominent in the areas of intense inflammation. Here's a little closer look at a typical case of nephronophthisis, again showing the interstitial inflammation. In this area, all of the tubules are atrophic with interstitial fibrosis, and yet again there's relative sparing of the glomeruli. Many glomeruli will ultimately undergo glomerulosclerosis, as we can see in the right-hand panel, but still, even in end-stage disease, some degree of glomerular preservation is quite common. Trichrome stain again demonstrates the diffuse interstitial fibrosis. PS stain highlights the periglomerular fibrosis and also shows the prominent tubular basement membrane duplication. The older literature emphasizes tubular basement membrane replication or duplication as a typical feature of nephronophthisis. However, anyone that's looked at many renal biopsies in patients with CKD of whatever cause, tubular basement membrane replication is a feature in common with many renal diseases. NPHP1 often has several distinctive biopsy findings that should prompt confirmation by genetic testing. Generally, this is by FISH or PCR. Three alterations are particularly prominent in NPHP1. The first is so-called floret-shaped tubules. And here's a floret-shaped tubule in the left panel. You can see it has a very complex profile, which in 3 dimension is sort of difficult to picture. A normal tubule, whether it's normal atrophic, is either going to be cut in a cross-sectional profile or longitudinal profile. So these floret-shaped tubules are quite unusual and not seen in other forms of chronic kidney disease. The second feature is tubular macula densa-like nuclear arrays. And the middle panel shows an example of that. So similar to the macula densa epithelium of the juxtaglomerular apparatus, these nuclear arrays consist of a tight row of densely packed nuclei that populate just a portion of the tubule itself. The third feature that is often seen are tubular diverticuli, shown in the right panel, where here we have a diverticulum where the epithelium is outpouching into the interstitium. The tubular basement membrane ends about right here and right here. And it's possible that these tubular diverticuli, when multiple, ultimately result in a floret-shaped tubule. I am not certain of this. Now here's a biopsy from a 7-year-old male in which the NPHP1 mutation was confirmed following biopsy. He presented with polyuria, polydipsia, elevated creatinine at 4.3, and no corticomedullary cysts noted on imaging studies. The biopsy shows a chronic tubulointerstitial nephritis, and if we look at the left panel, we can see prominent interstitial inflammation with extensive tubulointerstitial scarring. The middle panel shows a somewhat complex tubular profile with a significant area of macula densa-like epithelium, where the epithelium again shows tightly clustering of the nuclei, much different than the contralateral portions of the tubule. The right-hand panel again shows a floret-shaped tubule with a very complex profile. It has tubular diverticuli and also macula densa-like areas. Here are some additional tubules from that biopsy. The one on the left shows a somewhat star-shaped tubule, whereas the middle panel shows a tubule with a complex profile. And the tubule on the right shows a tubular diverticulum bracketed on each side by macula densa-like nuclear arrays. This is an example of a more advanced stage of the disease. This was a 19-year-old female, biopsied again for unexplained chronic kidney disease. The creatinine was 6.4, and in this case, a few medullary cysts were present, possibly because this is a more advanced stage of the disease. The biopsy core, as you can see on the left, shows extensive tubular interstitial scarring, as well as global glomerular sclerosis. The glomerulus in the center here is relatively spared and shows periglomerular fibrosis. Trichrome stain again shows prominent tubular interstitial scarring, and you'll note there are 3 relatively intact glomeruli within this extensive areas of scarring, again showing relative glomerular preservation. Here are some tubules from that biopsy. This tubule on the left shows a complex tubular profile with tubular diverticulum, maybe a small one starting to form here and a more obvious one at the upper portion. The tubule in the middle again shows a complex tubular profile, possibly the same tubule but at a different level. The tubule on the right again shows the complex tubular profile characteristic of floret-shaped tubules. And again, in this case, the MPHP mutation was confirmed. As I indicated, the infantile form of nephronophthisis has some distinctive features. These kidneys tend to be enlarged, often enlarged at clinical onset, and the enlargement is due to the presence of multiple cysts. And in the infantile form, the cysts often involve not only tubules but also glomeruli. In the panel on the left at low magnification, we can see a couple of glomerular microcysts as well as tubular microcysts. And the panel on the right again shows tubular microcysts and a nice glomerular cyst. The background tubulo-interstitial regions tend to, as a rule, show less inflammation, and the tubular basement membrane replication or duplication is generally less prominent. Here we can see the end stage of nephronophthisis at autopsy. As I indicated, 30% of cases will have medullary cysts. We have two gross photographs on the right. On the upper panel, most of the cysts are medullary cysts. On the lower panel on the left, we can see 3 or 4 medullary pyramids that are totally transformed by cystic alterations, some of the cysts quite large. But notice there is a medullary pyramid here that is spared with no obvious cysts at gross examination. And this medullary pyramid here on the left shows some small cysts. The Holmont preparations on the right again show, in the upper one, large medullary cysts, whereas in the bottom panel we can show variability of cyst size between the various pyramids. So there's variability in the distribution of cysts in end-stage disease. And it's easy to envision how a renal biopsy may not contain any cysts or may contain cysts depending on the sampling provided. Here's an example of the end-stage kidney at higher magnification. Although we have extensive glomerular sclerosis and tubulo-interstitial scarring, we still have relatively intact glomeruli scattered throughout the cortex. If we look at the medullary cysts, they are very nondescript in nature, lined by a flattened to attenuated epithelium, possibly of collecting duct origin. Moving on to autosomal dominant tubulo-interstitial kidney disease. Like nephronophthisis, this is a rare disease, but it's third in incidence behind autosomal dominant polycystic kidney disease and Alport syndrome of genetic causes of end-stage renal disease in adults. Autosomal dominant tubulo-interstitial kidney disease has a clinical phenotype very similar to nephronophthisis. There is unexplained chronic kidney disease, a lack of hypertension, proteinuria, and hematuria, and again, no history of other causes of a chronic tubulo-interstitial nephropathy or nephritis, such as drug exposure, supplements, urinary tract infection. Autosomal dominant tubulo-interstitial disease, however, has a number of features that make it stand out distinct from nephronophthisis. The patient is usually older, an adult rather than a child or teenager, although there is some overlap between these two diseases. Since it's autosomal dominant, multiple family members are usually affected by chronic kidney disease. It turns out the age of onset and severity within families varies quite a bit. Hyperuricemia is very common, present in 2/3 of patients, and this is not seen in nephronophthisis. And some mutations have unique clinical features or biopsy findings, as I'll illustrate in a moment. Here on the left, we can see the 6 known mutations identified with the recommended terminology for identifying these individual mutations in autosomal dominant tubulointerstitial kidney disease. Notice there is an NOS category as well, because these 6 mutations do not account for all cases encountered, so other genes are likely to be identified moving forward. The panel on the right is an interesting diagram from an article by Kinomo et al. And it lists in the center the features in common for the various types of autosomal dominant tubulointerstitial kidney disease. And then in the boxes associated with the mutation, several of the features they have which kind of set them aside as distinct from the other mutations. And rather than going through all of this information, one can generate an algorithm, or if you will, a hierarchy of genetic testing, which I've shown here. And this is largely derived from the previous diagram. Uromodulin should be considered for 2 reasons. First of all, if gout is a significant portion of the disease, uromodulin needs to be entertained. And uromodulin is the most common of all of these, so it's important to consider first. The biopsy is nice because it shows intracellular uromod inclusions in the ascending limb of Henle in the majority of cases, so we have a biopsy finding that can support the possibility of UMOD-related disease. Mucin-1 is the second most common cause of autosomal dominant tubulointerstitial kidney disease, so it certainly must be entertained if UMOD inclusions are not identified, and if gout, anemia, and hypokalemia are absent, which are features of the third most common entity, renin. Now, gout does occur in mucin-1 mutations. However, it's somewhat less prevalent than in UMOD mutations. Renin mutations should be considered if hyperkalemia, hypotension, or anemia are an issue, and childhood onset may occur because of the hypotension may lead to acute tubular injury at an early age. Hepatocyte nuclear factor 1 beta is a transcription factor important in the development of a number of organs, so these patients may present with a K-cut, renal or lower urinary tract abnormality, genital malformations, or diabetes due to pancreatic hypoplasia. DNA JB11 is distinctive because patients often will have a combination of kidney and liver cysts, which always raises the possibility of the far more common autosomal dominant polycystic kidney disease. And SEX61A1, these patients tend to have early onset renal disease and overlap with nephronophthisis. Now here's a typical example of UMOD mutation. As I indicated, it's the most common cause, so it always needs to be considered first, accounting for 37% of cases. The mean age of onset is about 54 years. And uromodulin, or TAM horsefall protein, is a normal product of the thick ascending limb of Henle, and these tubules are injured early on in the disease. So at times in a biopsy showing a combination of scarred and non-scarred areas, sometimes the scarring will be in strips of tubulointerstitial fibrosis. And in these areas, we want to look for the uromodulin inclusions. Now, the uromodulin inclusions are most readily seen, most easily seen on trichrome stain. So if we look at these areas of tubulointerstitial scarring shown here and look at higher magnification in the upper right, we can see these fusionophilic intracellular inclusions representing uromodulin retained within the cytoplasm. Again, these are quite prominent. It's quite frequent when you see a case of uromodulin, when you look for these inclusions. Once you find the first one, it seems like finding additional inclusions becomes much easier. The challenge, of course, is to find the first one. Here's another example of UMOD mutation. This was a case report by Nasser et al. In 2008. The trichrome stain in the upper right shows the nice UMOD inclusions, easily seen. And in this paper, they also included electron microscopy, which shows the uromodulin protein, which is retained in the smooth endoplasmic reticulum of some thick ascending limb of Henle cells. Now, immunoperoxidase can be used to confirm UMOD inclusions, but it is a messy stain. And by that I mean it's a messy stain because the normal thick ascending limb of Henle contains uromodulin, so it will show diffuse cytoplasmic staining. And this is shown in the upper two panels, where we have diffuse cytoplasmic staining. So if one is looking for a UMOD inclusion, you're looking for a rounded inclusion, if you will, of positive staining within cells that already stain positive. So in the lower panel, we have a uromodulin case, and right here we have a somewhat darker inclusion representing uromodulin. Here on the right lower panel, again another one. The uromodulin stain, however, can also be used simply to identify the thick ascending limb of Henle tubules. And this allows you then to go back to your trichrome stain and identify which tubules are a thick ascending limb of Henle and may permit identifying the uromodulin inclusions more readily on your trichrome stain. This is an example of an NPH1 confirmed mutation case. This is morphologically mild. The biopsy was very limited. You can see here a little bit of cortex on the left that loops around with a little bit of medulla. If we look on the trichrome stain in this area right here in the upper right, if we look at higher magnification, we can see in this area the very distinctive uromodulin inclusions within thick ascending limb of Henle cells. Now, Mucin-1 mutation. Mucin-1 is also epithelial membrane antigen. It's a normal product of multiple tubules, thick ascending limb of Henle, distal tubules, and collecting ducts. And this is shown in this normal kidney in the upper right panel on immunoperoxidase stain. These images on the right were taken from Helen Liepas's chapter in the Colvin-Cheng textbook on Mucin-1 mutation. In the upper right, we can see a medullary ray with thick ascending limb of Henle and collecting ducts staining positive. And in the cortical labyrinth, in the upper portion of this image, we can see distal tubule staining. The light microscopy, like other cases of autosomal dominant tubulointerstitial disease, simply shows tubular atrophy and interstitial fibrosis, and some degree of glomerulosclerosis will often be also be identified. Again, very nonspecific features. Now, it's possible immunohistochemistry can play a role in the diagnosis of Mucin-1 mutation. These are images taken from a case report in which immunohistochemistry was performed for wild-type Mucin-1, or normal epithelial membrane antigen, as well as the frame shift mutation protein called Mucin-1-SS. The panel on the right shows a healthy control, the upper two images, whereas the lower two images show the Mucin-1 mutation. These images may be a little confusing because the left-hand images actually are taken from the outer medulla, whereas the right-hand images are renal cortex. Nonetheless, if we look at the normal kidney in the outer medulla, we can see multiple collecting ducts and thick ascending limb of Henle staining positive for epithelial membrane antigen, whereas the mutated FS Mucin-1 protein immunohistochemistry is completely negative. Conversely, if we look at a patient with a Mucin-1 mutation, the staining pattern in the outer medulla tubules shows an interrupted and more globular pattern of staining, whereas the mutated FC protein is positive in the distal tubules in the cortical labyrinth that's shown in the right-hand image. Moving on to the renin mutation, heterozygous mutation of renin are very common or very uncommon cause of autosomal dominant tubular interstitial kidney disease. Only 30 families have been reported as of 2022. Homozygous mutations of renin cause renal tubular dysgenesis, a disease I will be discussing in the last segment. These patients characteristically present with hyperkalemia and hypotension and are at risk for acute tubular injury, and it's possible renin immunohistochemistry may play a role in identification of this mutation. This is based on a single case report, again by the same group, published in 2022. On the right-hand panel, we see a healthy control and an individual with a renin mutation. Renin immunohistochemistry in the healthy control shows a positive staining for renin in the afferent arterioles of the juxtaglomerular apparatus, whereas in patients with a renin mutation, apparently no renin staining positivity is identified. Hepatocyte nuclear factor beta 1 beta causes many types of renal disease. They account for 20 to 30% of cases of K-cut and also cause pancreatic hypoplasia with development of diabetes, liver disease, and can cause genital malformations. So multiple malformations may occur as a result of this mutation, and they may occur in combination. That said, isolated or clinically predominant chronic tubular interstitial nephritis is one of the least common presentations with this mutation. If we look at a large series of 75 patients with this mutation, only 2 patients were found to have a chronic tubular interstitial nephritis. So again, mutations of autosomal dominant tubular interstitial kidney disease due to this mutation are very infrequent. And the same can be said for SEC61A1 and DNA JB11. A total of 4 and 11 families respectively have been described by 2022. There are a few distinctive clinical features. The SEC61A1 tends to have childhood onset, and they often have hypogammaglobulinemia and neutropenia and are at risk for recurrent respiratory infections. DNA JB11, as I indicated, have a combination of chronic, have cystic liver and kidney disease, and therefore bear some resemblance to autosomal dominant polycystic kidney disease. The patients tend to have a very slowly progressive course with end-stage renal disease delayed into the 8th or 9th decade. And this is just an example of a biopsy from showing autosomal dominant tubular interstitial kidney disease, which is Mucin-1 versus not otherwise specified type. This is a biopsy from a 28-year-old male with a creatinine of 2.2, concentrating defect, but no gout. The kidneys were normal size without cysts, a strong family history of end-stage renal disease affecting father and grandfather, and the father was diagnosed as so-called medullary cystic kidney disease. The biopsy showed no uromodulin inclusions, and the patient didn't have gout, so uromodulin becomes unlikely. On statistical grounds, Mucin-1 would be most likely, but this would require genetic testing to determine. In the absence of a positive genetic test, it could be that this is a not otherwise specified type. The biopsy shows, as we've seen before, periglomerular fibrosis, prominent interstitial inflammation, and diffuse tubulointerstitial scarring, typical of a chronic tubulointerstitial nephritis. These are examples of end-stage disease at autopsy and at nephrectomy. The gross photograph here is an autopsy kidney, and here is the corresponding whole mount preparation. We can see in both the gross photograph and the whole mount numerous medullary cysts of a variety of sizes, but there is also scattered glomerular cysts as well. In this nephrectomy specimen, there's massive cystic alteration of the medullary pyramids. And here on the right, we have another whole mount from a different case showing prominent tubulointerstitial inflammation, as well as numerous medullary cysts associated with medullary inflammation as well. So just some examples of end-stage renal disease associated with autosomal dominant tubulointerstitial kidney disease. The mutations responsible for these cases is not known because these cases were encountered prior to genetic testing for this disease. Finally, I have a table in which I've listed both nephronophthisis and autosomal dominant tubulointerstitial kidney disease, and we can compare and contrast these disorders. They both are very rare. Autosomal dominant disease, of course, is going to manifest in multiple generations. Nephronophthisis has, in general, a much earlier age of onset and a much earlier age of end-stage renal disease. Medullary cysts may be seen in either disorder, but they tend to be a late finding in both, but may occur early on in both hepatocyte nuclear factor beta 1 if K-cut lesions are present, and may also occur earlier in DNA JB11. Both entities have extrarenal syndromic symptoms, which in the case of the autosomal dominant disease, K-cut and diabetes, congenital abnormalities suggest the hepatocyte nuclear factor 1 beta, liver cysts suggest DNA JB9. In terms of laboratory abnormalities, hyperuricemia and gout will most often implicate uromodulin disease, but mucin-1 mutations would be the second most common. In terms of clinical features, hypotension, it would be a feature of renin mutation, and both of these, of course, have progressive chronic kidney disease with none to minimal glomerular alterations, although in advanced disease, glomerular sclerosis is common. Well, this concludes part 5 of my 6-part series. The 6th part I've listed as miscellaneous cystic and developmental abnormalities. The 5 entities I will discuss in that section are listed here. 2 of these are quite commonly encountered on renal biopsy, and I hope you will tune into this final session. Thank you.